And so about a year ago, I moved into a different position in state government. I became the director of the state refugee office. And it was a nice change, I'm going to be honest. And it was really fortuitous for me because about a few weeks after I took on this position, the very big event happened in Afghanistan with the U.S. pulling out and the evacuation there, and then so many Afghans having to leave in what you could see was pretty tragic ways, rushing to the airport, some people literally hanging on to aircraft as they were pulling off, the desperation there. And fortuitous for me because I actually worked in Afghanistan about 20 years ago, just after the Taliban fell, actually. And so it really felt close to me. I still had friends, Afghan friends there, and some who had come here. And so to be able to be on the other side and to feel like I was in a place where I could welcome in the same way that when I was there, Afghans welcomed me and were amazing hosts was a great thing. And so I was really glad that that was kind of the first population that I had to dive into because I did have some familiarity, certainly not an expert, but some familiarity, which was great. So my office is the State Refugee Office. It's within state government, within the Agency of Human Services. It's not in any particular department. It just sits on its own, and it coordinates with a variety of other offices. So Refugee Resettlement, the mission of Refugee Resettlement is to promote and provide a safe and welcoming home for refugees and immigrants, and to promote their full participation as self-sufficient individuals and families in the economic, social, and civic life of Vermont. And all of those parts are important. The federal government, when they think about refugee resettlement, their really main focus is on the economic self-sufficiency. That's what they're looking for in our data, our outcomes. That's what they want to fund. So a lot of things go into that, but that's kind of their measure of success. Can a person become self-sufficient? And so that's one of the goals we work toward. But of course, everything else we do feeds into that. And so just briefly talking about what is a refugee, unlike somebody who leaves because there's a lot of poverty and they're looking for a new opportunity, a refugee is someone who is forced to flee. There isn't choice in being a refugee. They're forced to flee their country of nationality. They're unwilling to return to that country because of persecution based on the person's race or religion or nationality, membership in a particular social group, political opinion, war, or violence. In the U.S., when a refugee is admitted, they can apply in 1 year for permanent resident status. So having a refugee status as an immigration status is a pathway to citizenship. You can get a green card, and then eventually you can become a citizen. It's much more solid than some of the other statuses that you might hear about. And I'll talk about that a little bit later. But generally, I'll use the word refugee broadly, but I'll break it down a little bit because we do have a lot of folks coming in the past year and right now who aren't officially refugees. We treat them like refugees in terms of the services, but their immigration status is a little shakier, and it does contribute to their sense of instability. There are about 26 million refugees worldwide, but less than 1% are resettled permanently in a country each year. And most remain refugees on average for about 5 years before resettlement in a new country, and some for decades. So when I used to do my international work, I would go into a country, and sometimes there'd be an internally displaced persons camp or a refugee camp within a country. And although it was supposed to be temporary, what it really became was sort of a slum city for years, and there'd be generations. So there'd be a mother who's a refugee now with a 4-year-old who's now a refugee, or a 6-year-old, probably not going to school, maybe going to something that they've organized within the camp. And so it can be generational as well. What we saw with the Afghans coming over is different. They came immediately, and some of them came immediately from a middle-class background, so in some ways more of a shock because they didn't have years to kind of acclimate to that kind of life and that kind of self-described state. And so in some ways more shocking, I think, for some of the folks who came very quickly. I wanted to talk to you a little bit about how it works because when I took this job, I realized, A, I didn't understand how it worked, but B, a lot of folks don't know the structure of how it's all set up, and I think it's helpful. So who actually decides how many refugees are going to come to the U.S.? That's a presidential declaration. And so the president decides each year, usually at the beginning of the fiscal year. So last year that was October 2021. So he'll be making another announcement. And the president says, this is how many refugees we're going to take this year. And so last year, Biden, in an effort to shift what had been happening with the refugee admissions, said our goal is 125,000 refugees. This year, he'll probably make another declaration, and he'll probably try to hit that same number, 125,000. But that's refugees. So those are people who are given refugee status before they arrive, and they come in through the usual refugee system. However, what we saw last year was about 80,000 Afghans come in, but they didn't come in as refugees. They came in as humanitarian parolees. It's a special status that's not given out very often. It's usually given out in an emergency like this that the U.S. is somehow involved in. And so Congress basically passed an act that allowed for this pretty large group of Afghans, many of whom were directly connected to helping our military over years, come in through that status. Initially, when they were given that status, humanitarian parolee, it didn't come with any benefits. So resettlement agencies were scrambling to say, well, what are we going to do? Because they can't get Medicaid, they can't get Reach Up or TANF, they can't get food stamps, and so we're going to have to pull together a lot of resources. So Congress did pass an act soon after that said, we're going to make them equivalent to refugees in terms of the services that they can get, which was a big relief for a lot of folks recognizing that they wouldn't have to raise that many private resources. So that was helpful. So in terms of Vermont numbers, we were at about 350 a year from 2008 to 2016. And then the Trump administration reduced that, and we were down to a low of 23 refugees in 2021. And now we're back up to about 290 in fiscal year 2022. So that's generally kind of our trajectory. And then where are people coming from? So most of our numbers this year were Afghanistan, but you can see we've had in the past years numbers from Bhutan and the Congo. You can see Ethiopia, Iraq. We had Syria as well. So welcoming refugees in this past year. So we received about 260 Afghans, mostly humanitarian parolees. Some were under special immigrant visas, and that's where they were working closely with the military and were able to prove that early on and be able to get that visa early on. But many of the others were in process, and that visa process would have taken a long time, and they were moved out of Afghanistan very quickly. So rather than not move them, they were just quickly shifted to humanitarian parolee status and then moved out in that way. And then approximately 30 other refugees. So as you can imagine, with all the Afghans coming in, that also slowed down the movement of all other kinds of refugees coming in. So again, an inequitable thing in that there are people in refugee camps who may have had their ticket, so to speak, to come here as a refugee and then had a pretty big delay because we were overrun with a very large group of Afghans that the U.S. government kind of put in front of the line. So this year, hopefully, the goal is to catch up and bring a lot of folks who have been waiting in. So the way it works, so I mentioned the president makes the decree, so that's how many we're going to get. And then the normal refugee process begins overseas, and people either go to the UN or go to embassies and get their refugee status there. And then when we determine how many are coming in and when they are coming in, there are 9 national resettlement agencies, and their job is to do the work of the community resettlement. They get together and say, okay, this is how many's coming. How many are you going to take? How many are you going to take? And then they look at their offices in states, and they say, okay, let's say we have 2 resettlement agencies here. We have USCRI and ECDC. So the USCRI national office will say, okay, Vermont, how many can you take this year? And so the USCRI office here will look and see how well they've been able to resettle people. They'll consult with the community. They will consult with the governor's office or my office and say, okay, this is how many people we can take. So that's generally how it works. So for this coming year, we've got USCRI, that's the Colchester office. We've got ECDC, that's the Brattleboro office. But they're asking to open 2 new offices with staff. They already settled some people in Rutland, but they'd like that to be an official office, so there's staff there. And in Bennington, they resettled folks, but they'd like that to be an official office with staff there. So if that's all approved, we would have 4 sites in Vermont, 2 with USCRI, Colchester, Rutland, and 2 with ECDC, which is Brattleboro, Bennington. And so for this coming year, all of that combined, they collectively said, we have the capacity to resettle 500 people, so not families, but people this year. Of course, the biggest limiting factor is housing, and we'll talk a little bit about that. And that number isn't set in stone. If you begin to resettle people and you get to a point where we can't take more, they tell their nationals. But that's generally how the planning works. So the governor doesn't say this is how many people we want or we'll take. What happens is it's a kind of a negotiation, but it's really led by that resettlement organization, and the federal government has a direct relationship with them. So when people first arrive, the resettlement agency has kind of a checklist of things that they have to do as per their contract with the feds. They have to pick them up at the airport and get them a warm meal. And it's amazing who you see helping out with this. Like in Burlington, at the airport there is one woman who actually provides all the hot meals for any Muslim arriving family, because she was also a refugee at one point from Bosnia. And so she cooks, with halal foods, and she literally has all the food in her home. Somebody comes and picks it up, and it's all in containers, and it goes to the airport. And as people are driven to their home, they can sit down and have this hot meal, and that is this one woman's, that's her give back, so she is at the ready, and she cooks for all of them. And so that might be, every week or every couple of weeks she's cooking a big meal, which is kind of amazing. Now, in the past, you get picked up and you'd be brought to where you're going to be, your new apartment. As you can imagine, that is not so easy in this housing market anymore. But it used to be, even though the housing was tight, resettlement agencies would work with a small group of private landlords who had good success renting to refugees, and they were able to continually find places for them. But things had gotten very tight, so they shifted to some other models. So for example, in the Brattleboro-Bennington area, they shifted to a model where some folks, many actually, went to stay at the School for International Training, run by World Learning, and so that was transitional housing there, which was very convenient. They could get food there, they could get education, cultural orientation, English language. In the Colchester area, Chittenden area, USCRI went with some host families, and so for some people, they were given a host family, maybe a former refugee family or an American-born family, and they stayed with them for a few weeks while they looked for housing. That happened in the Chittenden area, but it also happened in Montpelier and Rutland. And then folks were eventually placed in long-term housing. And then the resettlement agency provides an appointment for the domestic health assessment, which I'll touch on briefly, and helps them locate a primary care provider. And then there's help with enrolling in the benefit programs like Medicaid, Reach Up, Refugee Cash Assistance, SNAP, and WIC. So just briefly here, we talked about the welcome money, the cash assistance. I should just be clear about how much that is. So if you're a single and you're not on Reach Up because you don't have kids, that's about $550 a month. So it's not a lot. They can get that for up to 12 months, depending on how much money they make. And then Medicaid. They can get Medicaid. If for some reason they weren't eligible, for some reason if they had too many assets coming over, they would be eligible for refugee medical assistance for a period of time, which acts like Medicaid. But mostly almost everyone in Vermont, when they come over on refugee status or humanitarian parole, are eligible for Medicaid. And then they can get WIC, Three Squares Vermont. They can also get child care assistance. So with the exception of that amount of money for a period of time, they're pretty much eligible for anything that any other lower income Vermonter would be eligible for. All right, and just briefly, current activity and outcomes before we slide into the health piece a little more. So on the Afghan arrival, 75% of those who are looking for work are now working. The hourly rate in FY21 was $15 an hour. We expect that will be higher. That's on average. 80% of those working do have health benefits with their jobs. 95% have secured long-term housing. Again, it's a little rickety with the emergency rental assistance going away. All children were enrolled in school. And then health and mental health. Everyone receives the domestic health screening. Almost all have primary care providers of those who arrived. Several are on waiting lists for mental health services. So just touching on the refugee experience and the trauma, you can imagine the challenges, the language, the transportation, the isolation, the cultural acclimation, and the history of trauma. Not all refugees have suffered torture. Some have, many from Afghanistan. Some of them have suffered that. Certainly a lot of them persecution or family members who were persecuted. And so, they're coming over with a lot. Because of the nature of the process, it's go, 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 and they get here, and it's go, 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 and after a few months, and then it floods in, and then you might really see some of the traumatic, the symptoms from the trauma show up. And so there's a great deal to acclimate to. The language alone, it is exhausting to have to think in another language for any of us who've traveled to other places. And when you have to do that all day, and you're doing it for your life, you're doing it because you've got to. The amount of things people have to sign up for when they come is amazing. They have to enroll their kids in school, sign up for Medicaid, which doesn't always take a couple of weeks. They have to sign up for Social Security. They have to meet with a case manager. They might be meeting with a lawyer. There's just an incredible amount of appointments, all in a different language. And depending on where you've come from, you may not even be literate in your own language, and you might have limited education. So it might be difficult for you to understand regardless. So it's a lot. So the domestic health assessment, this is the assessment folks get when they first come. And I say folks get, and I mean you guys give it to them. Thank you. Thank you for doing that. It's a big lift. And I want to say before we get into the health stuff, it is a big lift, and it can feel overwhelming. The thoughts of, do I have interpretation in place? What's going to come in here? Do my providers have experience in some of these illnesses? I'd like to refer them to mental health. Do we even have any capacity for that? Look at their teeth. We don't have anyone on dental to help them out. It can feel overwhelming. But I do have to say, when I talk to the providers who do this a lot, I'm thinking about Dr. Andrea Green. I'm thinking about nurse practitioner Paquette in community health centers of Burlington. And I know there's more, of course, in Bennington and Brattleboro, but I'm thinking of the folks who have done this for years there. The reward can be amazing because you can really see people go from a pretty low status and quickly, benefit from some pretty simple interventions because they may not have had them before. And so it can be very rewarding. So the domestic health assessment is the follow-up on any medical issues like Class A or B conditions that may have been identified. Normally, Class A or B conditions are conditions that wouldn't allow someone into the country, but most of them have waivers, with the exception of drug addiction, but the rest do. And so sometimes there's follow-up there. Identifying communicable diseases, contacting public health. Tuberculosis tends to be one that's relatively common. An interesting cultural piece, when we were finding latent TB in some of the Ukrainian children, the parents of one of the children was very concerned about getting their child tested because in Ukraine, if you're tested and you're positive, then your child would actually go away to a facility for a little while and be separated from you. And so the parents were worried about getting their child tested because they thought it meant that their child would have to go somewhere and be away from them for several weeks. And so it wouldn't have occurred to our public health nurses to have to explain that because they didn't know that that was the practice in Ukraine. So much you learn from just asking and listening early on. And making referrals for any needed specialty health care, et cetera. And so we have expanded our health network. So it's been a really big year of growth, and I know some challenges for a lot of new partners who've had to dive in very quickly with probably not a lot of guidance. In the past, it was really mostly UVMMC, Community Health Centers of Burlington, and then now we've added Rutland more so, and then, of course, Brattleboro and Bennington very quickly stood up, all kinds of response. And once again, just the compassion and the willingness to say, oh, okay, how can we do this better? How can we meet the needs? And at the same time, working with a brand new resettlement agency who also didn't know a whole lot about it yet. And so everybody learning together, there's some frustration, which happens occasionally, but a lot of success. In the Brattleboro area, they have a different model than in the Colchester area. In the Brattleboro area, they have a model where there's a resettlement agency, but there's something called community sponsorship, where groups of people come together and they contribute funds, and they basically take on the day-to-day kind of care for refugees. And so they might, help them get to appointments. They might help them get, food, help them enroll, things like that. There's some real benefits to that program. They get a lot of support, but it's also tricky because it's new. The roles haven't always been clear. And so you can go from being a person who drives someone to an appointment to feeling like you're somehow responsible for making sure that they understand all of the medical instructions they've been given, right? So it starts to bleed over a little bit, and it gets really tricky. So it's getting updated, the domestic health assessment. The tuberculosis screening and diagnosis guidance is getting updated. This should be out in a couple of weeks. Expanded standard screening guidance for lead. Here in Vermont, because of the way these forms were done in the past, we had relatively low levels for lead testing on these forms. The mental health screening section. I know we were screening for mental health, but we showed that we were hardly ever screening for mental health on these forms. So the federal government came back and said, why doesn't Vermont screen refugees for mental health? I said, I think we do. I think it might be a form issue. So we're working on that. And streamlining the immunization documentation process. Again, the domestic health assessment it's Medicaid. You can charge Medicaid for filling it out. You can also charge Medicaid for use of interpretation every 15 minute slot. I know the reimbursement isn't high, but these things are reimbursable. So just a few cultural notes and how that connects into health for, we're just going to concentrate on Afghanistan because that was our biggest population recently. Their official languages are Dari and Pashto. English isn't routinely spoken. Many people require an interpreter. And we're learning a lot, about the interpretation. Some folks may have had interpretation services and used them a little less frequency. And now that it's picking up, folks are realizing, oh, okay, we might want a different kind now. If we're going to be using it this often, we're seeing maybe little glitches that don't work out. And recognizing we probably need to train more people. Yes, you need it in the medical interaction, but you might need it even at the front desk if somebody comes in and can't speak. So doing a little more work there, and folks are upgrading some of their interpretation services. Literacy levels vary greatly. So even if you do have something in writing in their local language, they might not be able to understand it. Literacy levels for women are very low in Afghanistan, and for men, a little higher at 55%. So education levels vary among Afghans. And you can see that with the folks who came over. We've got folks with PhDs who are lawyers, and we've got folks who didn't finish high school. So we've got a full range. And it's easy to meet one family and think the next family is going to be like that, and they might not be. So everything I say today you should take with a grain of salt because it's a little bit of generalization, and you might meet someone who's different, but these are the general things we see. Greetings. This is tricky. In Afghanistan, it's also something relevant among the Muslim population generally, but an Afghan might place their hand over their heart. I was with my partner, and we went to the Afghan New Year's celebration, and a woman came up and spoke with us to say hello. She was an Afghan woman, and he reached out to take her hand, and she awkwardly did this, and then he awkwardly put his hand down, and but she was smiling the whole time, and he learned after that it's just a nod. You're not going to grab a woman's hand, but he didn't know. So that's something you learn. And honestly, I feel like when refugees arrive, they're very patient because they know we don't know, right? So just being open to it and correcting it is helpful. So people do not usually touch the opposite gender. So when I lived in Afghanistan, in general, single women could not be in the vehicle with men who were not related to them. So we had male and female staff, and we had to be thoughtful about when we were driving out to a community who was going to be in the vehicle. So if it was one of our female staff, we might have to have other female staff in the car. And other than the male driver, we couldn't have other folks in the car. So it does get a little bit tricky with the gender. It also then, of course, impacts sometimes the care. Generally, women would prefer contact with a female doctor. And, we've had cases where women sometimes have requested an all-female surgical team. Might not be possible. But acknowledging it, I know why you're asking, and we recognize this is your culture, and this is why we might not be able to do it, can go a long way. Putting one's hand to one's chest is a respectful way to greet someone, so when in doubt, this is a respectful way to greet someone. Men and women keep eye contact to a minimum when they greet one another, and effective introductions, extensive introductions and other greetings are the norm, and so being able to just ask about family, especially in that first appointment, can go a long way. And then gender. Men and women have defined roles in the Afghan culture, and again, some of this might not be exactly what happens when you meet folks, but early on you will probably see that women generally are not given much of a voice. In an early medical appointment, the man might do all the talking, even if the questions are directed to the woman. Often, if you're able to establish some trust, when the woman comes back for the second appointment, she might be much more likely to be able to freely speak. It's a little tricky early on, and men generally make the decisions around the care, and so it does require a little bit of trust building to get to a place where you can engage a woman in some of these conversations. You might have folks who agree, and you've probably known this from other cultures where yes means maybe, yes, I heard you, but not necessarily, yes, I understand, or yes, I'm going to do that. And so you might need to use some of your teach-back methodology that you use for any other patient education to actually be able to check in to see what people have understood and what they actually want to do. But women are generally not free to make their own decisions. Of course, there are exceptions, and you may already know people in that exceptional group, but generally they're not free to make their own decisions. So some cultural considerations. We talked a little bit about this, but when we were talking about accessing cross-cultural issues, it's communication style, mistrust, family dynamics, spiritual customs and traditions, and sexual and gender roles. So we're going to talk just a little bit about a few of these: the meaning of illness, the social context, and engaging in negotiation. So that trust is important. Dr. Green maybe goes a little above and beyond, which is great, but she really makes sure she tries to find out how you do the basic greeting. If it's a new group that's arriving into Vermont, so for the Afghans, assalamu alaikum is just a basic greeting. And just like if you go anywhere and you give it a shot, people like that you tried. It's okay if you get it wrong. And so just being able to do that greeting can take a lot of the tension out of the air, especially on that first visit. The use of interpreters is really important throughout the visit. They can do more than just interpret. Ideally, in a perfect world, an interpreter is simply interpreting what's being said back and forth, but an interpreter in these circumstances can also be a cultural broker. They can pause if they see that the patient might not be understanding what you're talking about, because they can hear them talking and realize, oh, they're going down the wrong road. And they might pause and say, hey, I don't think they're understanding, can we talk a little more? Or the word you just used that I translated doesn't mean that for them. They have actually a longer or more different explanation of the word that you just used, so we might need to explore a little more. So let me talk a little bit about interpreters in Vermont. We don't have a licensing system. We don't have a formal certification system, but we do have professional interpreters. Many of them are not medically trained, and so that is a challenge. And by medically trained, what I mean is trained to be a medical interpreter. There is medical interpreter training, and in an ideal world, that's what we have. A lot of your hospital systems have a telephonic or video translation service, and that is great because a lot of those folks are probably trained as medical interpreters. And you know, just the other day, I spoke to somebody actually here in Manchester who brought in their patient, an Afghan, and had a fantastic experience with the use of, you know, right away somebody came up on the screen, was speaking Dari within a minute of the appointment, and was able to beautifully facilitate a pretty sensitive appointment. So it's an amazing tool. Some folks are hesitant to use it because just like frequency, just like I keep calling my IT people every time I have a password problem, I know I could learn how to fix it. But I'm overwhelmed, and it only happens once every 4 months. So frequency is tricky, right? If someone only has to do something once every 7 months, it's a big ask to ask, Robert at reception to suddenly pull out his manual and figure out how to do this. So you probably have to exercise it a little bit, or maybe even have a few champions that are comfortable with doing it. Ideally, the resettlement agency does a little bit of cultural orientation around our medical system, just a bit. Ideally, they explain when you go to an emergency room and when you don't, because that's really common, right? I'm sick, I'm going right to the emergency department. So that's really helpful early on. The idea of a pharmacist. In a lot of countries, you get your medicine right there if you see a provider. You certainly don't get a prescription, and then you don't go to another building 10 minutes away later on. And so the pharmacy piece is important. And then being on time for an appointment. It might be a culture where time isn't as relevant in terms of being on time, and so the importance of that. Ideally, the resettlement agency does a bit of that. So then in the first appointment, you might be just touching on it. But it is helpful to establish early on. For some folks, they might have been to doctors before in their home country. For some folks, they may never have been to a doctor, and probably not for preventive care. That's a special thing. In more developed countries, a lot of folks do not get preventive care. When they go to a doctor, they get medicine. And we have had folks come from overseas, and including the Afghans, who feel like if they go to the doctor and they don't get medicine, what's the point of going back? Because they're not doing anything for me. They might not understand that if they've got a viral illness, we don't provide antibiotics for that. And so that's where, and we'll talk just in a minute about how do we learn the way they think in order to be able to hear it and then provide the information that we need to provide. So some family considerations. When I took this job, I had to pull all the data and send it to the feds. One time a year, we do that to see how many refugees we're helping. And I looked through, and I had to record the birth dates. And there was one family where everybody was coincidentally born on January 1st. I was like, wow, that was a very busy day. And so in a lot of countries, there isn't a birth certificate. And that might be because it's rural, or it might be because poor record keeping, or that's not what they do. So often when they're coming over, that is just the default of what they write in as they're coming into the country for their birth date. And they might be able to correct that if they can find a birth certificate, but often that just remains their official birth date in our systems. So that will look strange, and there's a reason for that, and you might see January 1st. And you might be able to probe and find out it's a different date, but that might be the date they already put on their Medicaid application and on all their other paperwork. So if that's the date they're giving you, that's probably the date you're going to stick with. Even the year can be tricky, and that is something that's hard as a medical provider, because if you're way off on the year, there are screenings, there are other things that are age relevant that you want. So spelling of name and records. Names can be spelled differently. Names can be switched. A surname is not always in the front. Maybe everyone has the same, what looks like a first name. It's tricky. And so that's just something to be aware of and to try as much as you can to see if we can get source records. A second family. So especially Muslims can have up to, a Muslim man can have up to 4 wives. So most don't have 4, but often you might have a second family. And so somebody might be talking to you about brothers and sisters or their children, and it may or may not be the children right now that we're talking about in this family. When folks left Afghanistan, a lot of them left some of the children from their second family back home. They might have brought over the children who are most at risk, or who might have been with the primary wife. So when you're talking about family, and you're probably aware of this from some other cultures as well, brothers and sisters can be usually used as, as familial terms, but also when they're talking about children, it may not all be coming from that one wife. So some of the interactions, I think we mentioned here, male providers generally shouldn't shake hands with Afghan women unless it's offered. They may prefer to work with gender concordant health professionals. And again, if you can't, I think the acknowledgement first, I understand why that's important, and then to be able to explain it would be helpful. Modesty. Ideally, female interpreters should be used for female patients. During physical exams, of course, you have to remove clothing, but being able to cover certain areas, or being able to quickly dress again, or having males removed from the room is really helpful for modesty. And again, patriarchal. Women are the caretakers, but they will defer to the men. And this is something Dr. Green really noted, that she found that the men were very affectionate with the children, during appointments, and some women noted that the men did more cooking. So we have stereotypes sometimes, but people can have, people aren't all one thing, and so they might have some other pieces there. and just the trust expectations. You will see, of course, incomplete immunizations. When that happens, if you want to give a child another immunization, in our culture, we generally know, although you have to probably reassure lots of parents here too, right? Like, that's okay. You might next need to doubly reassure somebody coming from a refugee environment that it's not going to harm the child, because some of these moms and dads want to be acknowledged that, hey, I did do the right thing. I don't have the records, but yeah, I did give my kid those vaccines in my home country. So just acknowledging that and hearing it and saying, I recognize you did it. We need to do it again because we don't have a record and it won't harm your child. And again, around the antibiotics, there's a high expectation for medicine. So explaining what the value of the visit is, even if you don't get medicine, can be very helpful. And the dental care. We see a lot of dental issues. We reached out to the Dental Society to see if they might be able to stand up a few more free clinics. And it's a problem for all Vermonters. So all these things that I'm talking about, I don't mean to say that there aren't other Vermonters with some of these issues, but folks coming in, if they have an emergency need, that gets taken care of, but often, and they're afraid to go to the dentist too. They're not in a culture where you would just go every year unless there's a serious problem. And then the meaning of illness. This is very common to believe that illness is caused either by the evil eye or some kind of hexing, an imbalance of fluids or heat and cold in the body, or contagious, therefore unavoidable, right? The idea that something's contagious so you can't help it. So being able to ask about this is important around an illness. The hot and cold is interesting. So in many of these countries, because the water isn't clean, especially if you're sick, the expectation would be that you boil water in order to eat or drink, especially if you're not feeling well. And so it's really associated that you would give warm foods when someone's sick. So if you recommend like a Pedialyte sort of popsicle for a kid, that might seem strange because that's a cold food, but my kid's sick. And when my kid's sick, they're supposed to get warm food. So the warm cold actually comes up surprisingly a lot. And so to be able to reassure people that whatever their diet is, if they're getting liquids, it doesn't mean it has to be tea. It can be a cold liquid if you're asking them to take liquids, things like that. And the evil eye can feel very strange if that's not part of your culture, but having a judgment-free kind of listen to that can be helpful so you can get a sense of where people are coming from. And then treatments, especially the Afghans are Muslim, and when I was there, I can tell you that no matter what the environment, so I was setting up temporary schools for kids who had no school to go to. Very temporary, very rudimentary. And I remember we were talking about what's important for kids to learn. We were talking about, writing or math or other things. And they said the most important thing for kids to learn about is Allah. And we said, okay. So then we thought, how can we do this? And we said, well, what about this part? And so we kind of kept bringing in, would Allah like it if the kids learned manners? Oh, okay. Should they learn how to read? Should they, so we kind of kept pulling it in. But all that to say, religion is absolutely central. So to acknowledge it if folks are talking about it, and certainly just like if you had anyone else coming in, a Christian come in to say, I feel more comforted when I pray, you certainly would support that, whatever makes people feel comfortable, and it's the same along here. Does the pray cure you? Maybe not, but recognizing that that's an important part of people's spirituality. Ramadan is a very tricky time as a provider because folks might not be eating for most of the day. So if there's regular medications to take during the day, you may need to talk about that negotiation. You're going to take it maybe in the morning and after sun goes down, things like that. So just recognizing, and that's a pretty extensive period that people won't be eating during the day. These are Kleinman's 8 questions. You guys are familiar with probably Kleinman. It's really helpful when you're talking to other cultures. To be honest, I think it's helpful also when you're talking to folks who might not be interacting with the health system a lot or have a family culture, even here in Vermont. Or even, in our more rural areas, I'm thinking like an older farmer who never comes to the doctor. There might be all kinds of folks for whom these questions might be relevant, but what do you call the problem? Because once you find out what they call it, that might be a helpful way for you to be able to connect. What do you think has caused it? Why do you think it started when it did? They might tell you it started because there was stress. They might tell you it started because I went out and it was really cold one day. So then you'll find out a little bit about the way they're thinking. What do you think it does? How does it work? How severe is it? What kind of treatment do you think you should receive? What would you have received in the past? What are the chief problems? And what do you fear? So those are the kinds of questions to start getting at where someone might be coming from. And then just the social context, especially around mental health. And we have this here in our own society, but the taboo around mental health is pretty significant. And so we have found that in general, working with refugees, but particularly Afghans, not referring to it as a mental health problem, because in many countries, mental health is crazy, and that's the person who walks down the highway with no shoes on, and wears a ripped up shirt. And so using words like sad or stress can open up the conversation. And so we have found that people are getting a little bit more open to the mental health. We certainly know that some of the things they've gone through are having them show up. One interesting piece that came up was sleep problems. A lot of folks were having sleep problems, which was assumed to be related to trauma. But here's an interesting thing. This listen, explain, acknowledge, recommend, negotiate. Because one of the providers really took this listening piece very, very carefully. So she asked about the sleep, and then she asked a few more questions. And a lot of folks have circular ways of talking, and she really allowed that to happen. Turns out this guy, and not just him, a whole bunch of the Afghans coming over were drinking Monster drinks, those really high caffeine drinks, like pounding them, because when they were in Afghanistan, there were promotions going on, and so the companies would send over like crates of these, and so it just became the culture to drink them all day. And so some of these guys were like, I can't sleep because they're so jacked up, and they didn't realize it. And so in one case, he was drinking 4 a day, and he's down to 1 a day, and his sleep has tremendously improved. And so sometimes it's like a deep, horrible thing, and sometimes it's a Monster drink. And I don't think he would have connected it. We talk all the time in our culture about caffeine, right? So we might connect it faster. That was new to him. And she picked that up on just listening, trying to talk through, so tell me about your day. And he says, and then I drink. Oh, what do you drink? And then, the connection. So interesting. So yeah, this listen, explain, acknowledge, recommend, negotiate. So the acknowledgement is acknowledging, oh, that's how you see it. That's what happened. That's what you feel like should happen. And then the recommendation, and then probably the negotiation. Because after the recommendation, for a lot of folks, they defer to power. They'll say yes. That's not the same as yes, I'll do it, or yes, I agree. So then there's a negotiation. Okay, so I heard what you said. You heard what I recommended. What do you think you can do? Lead. We've got some high lead levels from some of the kids coming over. Not just from Afghanistan, but from other places too. It's common for little girls and boys actually to have kohl, kind of like an eyeliner, but it's really got high lead content put on the eyes. It's a way to ward off the evil eye, because infant mortality and mortality for children under 5 is really high in a lot of countries, and it can feel pretty inexplicable, but it's one way to ward that off, from a kind of traditional spiritual perspective. And so that might be a cultural piece. And so we think one of the reasons the high lead could be that it's absorbing in. So if folks want to continue doing that here, we might just be able to suggest a different product that doesn't have high lead, but still allows for that visual sort of look of an eyeliner. So that's not parents trying to sexualize their kids early with eyeliner. That's trying to keep them safe, and one of the ways they've learned to do it. There are a few other options, might have been because of their cooking pots or spices or even munitions, but they think that the coal is probably one of the reasons for that. And so again, just repeating those lead tests and to see if that comes down. And then this is our final example here. This is unique to Afghanistan. It's called Akika. And this is a celebration of a child's birth after the 7th day of life. A sheep is sacrificed, 2 for a boy, 1 for a girl, of course. And the infant's hair is shaved on the 7th day, and circumcision occurs. So here, mostly, kids are born in the hospital, and circumcision happens in the nursery, which is a real good thing. I think we could all acknowledge that. But you can do a lot of the other parts of it, right? So, hey, we do circumcision here, but recognizing, but I know you have some traditions, so they can still have the party. They can still have a feast. They can still shave the head. Again, it's just really, I think, the acknowledgement that things are different, and we recognize it, and this is how we do it. Vermont's providers have been great. I recognize Medicaid reimbursement isn't a lot. I recognize we don't have high numbers of refugees, so the infrequency can make it hard to keep your systems up, but you're still trying, and I appreciate it. I don't think we're going to go backwards in the next few years on refugees. I think there's going to be more folks from other countries in more places in Vermont. The government wants to start a private sponsorship program, the feds, and they're going to start piloting that, which means rather than folks showing up in centers, they might show up in small towns. Probably not high numbers yet, but we're going to see more people. So I appreciate your commitment to it. You've been so adaptable. You've been willing to do the hard work. Thank you so much for taking another look at your interpretation and being willing to train people up. My office has funds to also do some general training on how to use an interpreter in the medical practice. If you want to access those funds, I can just ask for them and the feds just give them to me. It's very nice. So I can pass them along to you. The refugee service community welcomes feedback. We recognize it's not always smooth. And I know in the southern area or Brattleboro, Bennington, it's been, it's been a little tricky as things are new. So we welcome feedback. I welcome feedback. But I just want to thank you again for everything you're doing for folks. The refugees speak wonders about what you do, what the community does here, and they're so appreciative. And so I want to pass that along. Thank you very much.